Good evening, friends. On this very first day of a new year, I wish you all a happy, prosperous, and healthy new year. On this very first day, I am glad to invite Professor Dr. Somashekhar Nimbalkar, who is Professor and Head of Department of Neonatology at Pramukh Swami Medical College, Paikaka University, Karamsad, Gujarat. Sir has been Editor-in-Chief of our own Journal of Neonatology of NNF. Sir has been Joint Secretary of KMC Foundation of India. He has been a chairperson of the year 2023 in IAP Medical Education chapter. Sir has been a national convener for IAP NRP FGM program for the year 2023. Sir is a member of International Pediatric Association in the Program Area Committee on Education and Public Pediatric Workforce for the year 2023 and 2022-2025. Sir has to his name various achievements and awards. Sir has been the coordinator of the NRP program, has been a member of NNF governing body, New Delhi. Sir is an associate editor for International Journal of Pediatrics, Frontiers in Pediatrics. Sir has been reviewer of several international and national journals. Sir has been awarded Fellow of Neonatology, National Neonatology Forum for the year 2021. Many publications are there. In short introduction, I request Dr. Somashekhar Nimbalkar to share his presentation and start the presentation on kangaroo mother care, innovation, evidence generation, and implementation. Thank you so much.
Thank you, Professor Dipen, for the invite and for the introductions. Good evening, friends. Happy New Year to everyone. Happy 2024. And I'll be starting my presentation. There are lots of slides, so but I have promised that I'll stop at 10 o'clock. So yeah, we are at 9:07, so I will try and finish by 10 o'clock. Maybe I'll not finish, but I'll definitely stop at 10 o'clock. So KMC innovation, evidence generation, and implementation. Why is KMC interesting? Because KMC is a particular topic that began in a country called as Colombia, which is in South America, and Colombia is famous for actually drugs and football. And you will have many Netflix series like Narcos, etc., talking about drugs in Colombia and all. But no one would talk about kangaroo mother care. But kangaroo mother care in the last 30-40 years has changed neonatology significantly. Neonatology is a pretty young branch, maybe about 60-70 years only in terms of advances that have taken place rapidly. Pediatrics is also a very young branch, maybe 100-150 years. So one of the advantages that KMC has had, which many adult sciences don't have, and neonatology is actually benefited because of its being a relatively new branch, that many of the practices that we do are evidence based. And so it was interesting to look at this topic from how evidence generation came about and what things have happened for evidence generation. So I'll be showing two PPTs. One is mine and one of Dr. Suman Rao's for IKMC at the real end, where I'll try and run the IKMC project in about 10 minutes or so. So beginning with KMC, these are the three people who are kind of credited with what KMC is known to us for. So Edgar Ray Sanabria, Hector Martinez, and Luis Navarrete. So these are the three people who kind of began working on KMC, and they are the ones who kind of innovated KMC. So this is kind of the timeline of generation of starting of KMC and of taking care. So I'll be taking you through this timeline. So it was conceived in 1978, and most of us know this from various presentations in KMC on KMC that Edgar Ray is supposed to have initiated KMC. We'll look at a later slide and see why it was initiated, but he initiated KMC in 1978. Then in 1979, another colleague, Hector Gomez, joined and took charge of the program. So it began in a small place, like most new things that start. they generally ignored and started off given small places to work in any hospital or any institute that looks at new things. And so this two people, three people kind of began formalizing this particular program. And the main thing was how to train mothers to take care of the babies, was the main stuff. And they taught mothers about breastfeeding, nutrition, stimulation, and disease prevention. So a lot of education and teaching mothers how to take care of babies. Uh, the third person, Louis, was also linked to the program in 1982. So in about 4 years' time, mainly in charge of disseminating knowledge. And in 1982, in the same year, the UNICEF regional office began supporting and disseminating the kangaroo mother care methodology. So you saw that in a period of 4 years, there was this thing which began and started getting supported by UNICEF in Colombia. Okay, and in 1991, roughly about 13, 14 years, the Colombian Ministry of Health awarded an award, Jose Celestino Mutis Award, and also the 44th Plenary Assembly of the WHO, another Saskawa Prize for Health was awarded to these doctors for contribution to of health in reducing mortality of premature babies and low birth weight. So you can see there's a lot of innovation, and there is barely any research that has happened before people starting receiving awards for something that they began. So this is not really evidence-based program or evidence-based healthcare, but this was based on what they saw. In 1994, there was this Kangaroo Mother Care Foundation, which was initiated roughly about 16 years after KMC started, to kind of evaluate the benefits of what was started. And in 2003, the WHO published a manual on how kangaroo mother care needs to be carried out. So you can see now that over a period of about 25 years from when the KMC started in Colombia to WHO publishing it in 2003. And mind you, this book hasn't changed. And I think last year or this year, it would get changed. So there is going to be a change in the book 20 years since it was published first in 2003. So this you can see these three doctors with the babies.
तुरंत जाके सयान को पहले भेज दो पे सयान सब नहीं गए क्या ये लगता नहीं है
So in the now this in 1990 in 90, between 1992 and 93, this person called as Natali Charpak joined this Infant and Maternal Institute, who along with a social worker and a psychologist and another Dr. Yolanda began the first research project on the KMC program between 1992 and 1993. Interestingly, Nathalie Charpak is a French citizen. She's the daughter of a Nobel Prize winning another her father is a Nobel Prize winning, I think, author or literature person, and she fell in love with a Colombian person and then shifted base to Colombia. So Colombia speaks usually Spanish, so this person learned in
हाँ?
French and shifted to
चलेंगे क्या
Colombia.
नहीं नहीं लगता नहीं है मैंने
The
आपको बोला है ना जाके रिलीव कर दो करके मैं अभी
this
जाऊंगा मैं रूम
this person is the person who kind of began uh, research or into kangaroo mother care. And this was one of the first slides that I've seen, which looked at KMC. But these are generally called as before after studies when done very properly. This is kind of simple data. The reason why KMC was started was because these hospitals were overburdened with newborn children. There's hardly anyone to look after them, and babies were getting abandoned, and babies were being left behind in the hospital, which many government hospitals know that on and off we are left with some abandoned babies. So here also, what they found is after KMC was started, the number of abandoned babies dropped. Even babies who were very small survived. Okay, and so even less smaller babies also survived. So this was not kind of very good research, but these are significant numbers for any methodology. So this kind of began. This was the reason why these people started getting awards, and this practice started getting adopted everywhere in Colombia. and WHO started pushing for it. So remember the date when I said WHO published the book 2003, and UNICEF kind of started pushing for it in 1984 or something around that, before that. So this was one of the first papers that was published that looked at stabilizing low birth weight babies. And here also, if you can see the last line, mortality was the same in both the groups, control as well as kangaroo mother care group. And most deaths occurred during the stabilization period before randomization. Okay. Another study that was done by Natali Charpak. So this was the first study that was published by Natali Charpak in pediatrics. And they looked at, this was not a very good randomized control trial, but one hospital which was looking at traditional care and another kangaroo mother infant care method. Okay, so these two, and so they compared this particular two particular hospitals. They called it randomized control trial, but it's not really a very good randomized control study. And what they found was uh, bo- uh, what they found was this, that the 162 at the Kangaroo Hospital and 170 at the Control Hospital, and there was a difference in the groups that were recruited to this particular groups, and hence when they looked at the final results, uh, they found that the low birth weight infants in Bogota, the survival was similar, despite they being much more difficult babies. And so that's the time that they decided to have a better randomized control trial. In between, this was another study that looked at kangaroo mother care and compared with incubator care. These are the general studies that were done at that point of time. And what they found was that it was almost similar, and it's a safe and feasible method for mothers and infants. I'm sorry for my voice because I've not been well for the last 4 5 days. Uh, Another study that was published in 1995, again to compare kangaroo mother care and traditional methods. This was in Canada. So Canada has an interesting connection to Colombia, that many of the studies, people in Canada have collaborated with people in Colombia. And they looked at 71 infant mother diets, and they found that kangaroo mother produced less variation in oxygen saturation, so physiological stability and longer duration of testing, and it was preferred by most of the mothers. And it said that the KMC method was safe for the preterm infant and allows for early contact between parents and infant. This was the study that kind of changed kangaroo mother care. So this was a proper randomized control trial. I mean, they looked at 1,084 infants and randomized 746 babies into KMC and to traditional care. Unlike the previous study that Natali Charpak published, these groups are similar and both had baseline variables, but the weight and it was almost similar, except for the little bit of weight. They found that the risk of dying was similar in both the groups, which means KMC is as good as traditional care, and nosocomial infections were more in control infants. They also found that hospital stay was shorter in KMC, especially for babies who were less than 1.8 kg. So they concluded that KMC is a safe approach, and this is like the first few years of studies, and it provides the necessary scientific support to a method that is already incorporated in the care of LBW infants at many hospitals around the world and at different levels of care. Subsequently, in 2007, this paper was published in Acta Pediatrica. If you look at from what this paper is published from the first international KMC conference that was held in Trieste, Italy in 1996. So almost 10 years after the conference was held, this paper was published, and there was recommendations for implementation of KMC for low birth weight infants. And what it basically said was it does not require expensive and sophisticated equipment and can be used anywhere. This is a follow-up study at 1 year of the earlier cohort of 746 babies, and they found that the number of infections were similar in both the groups and severity was less in the KMC group. And they said that the growth index of head circumference was significantly greater in the group given KMC, but the developmental indices of the two groups were similar. Now, this study is very important because this study is commented upon on a study that is done about 15 years later. Okay, so keep in mind this study. The first one, randomized control trial, which is not a good randomized control trial, published in 1994, followed by randomized control published in 1998. This is into the follow-up of that proper randomized control trial, follow-up at 1 year of age. This is the first study from India, published from AIMS, where they looked at 28 neonates and 14 given KMC and 14 not given KMC. And then they again said that KMC babies had better weight gain, better height gain, and so on and so forth. So generally, and also less time for discharge and so on and so forth. So what is the various Indian research? So this section says Indian research, but then I shifted straight to Cochrane. So there's a reason for that. Just give me a minute. Okay. So I talked about Cochrane, and you can see that in this Cochrane study in 2000, there's almost 22 years after the KMC method was kind of initiated or introduced in Colombia. There were just 3 good studies, randomized control studies that were there, and they found that there was no evidence of difference in infant mortality. Why is this important? Because this kind of changes in the way how people look at kangaroo mother care method. It says that it appears to reduce infant morbidity without any serious deleterious effect reported. So what it basically means is you can try KMC as much as you want to, but it is not better than traditional care. But if you want to do KMC, it's okay. It is not harming the babies in any way. So it kind of became an optional method for kind of if somebody said that KMC is to be done, then somebody might say, no, it is as good as traditional care. I want to do traditional care and I don't want to do KMC. So you couldn't argue with such a person if somebody wanted to prefer traditional care as of in 2000. Okay.
Yeah.
Now what happened is next, and this is the reason, and this is the forest plot of that. You can see that the diamond in the middle is touching the central line. 2003, again another systematic review. And if you look at the details down, the details are the same. Basically, there was no study published between 2000 and 2003. And so obviously the systematic review is not going to show any difference. So it's the same thing. But in 2011, we found that there are more studies compared to 3 studies. Now by 2011, over a period of 8 years more, there have been 13 studies added more, and the number of babies have almost doubled. And this one clearly says that kangaroo mother care was associated with a reduction in risk of mortality. Okay, and also found to increase some measures of infant growth, breastfeeding, and mother and infant attachment. What this means is now kangaroo mother care becomes a method of care which decreases neonatal mortality as compared to traditional care. Okay. Now, at this point of time, all the studies that are looking at this particular care is kangaroo mother care in babies who have been stabilized after birth, not unstable newborns. Okay, so these are the various studies that are there, and you can see on the right hand side this. I hope you can see the marker. This diamond is kind of not touching the baseline, so it basically is favoring kangaroo mother care. Okay, in 2014, again 2 more studies were added, and again similar conclusions. What I want to point out is the things that change the interpretation from no mortality to decreased mortality is actually these studies. Dr. Suman study, this is from KM Mumbai, and you can see that the events that were there are 5 and 1 in here, and you can see total babies 103, 103, really large numbers. Kadam was also a study from KM Mumbai. Gavan is a study from Hyderabad. So there are these 3 Indian studies that add a bulk of data to this particular systematic review. This is Dr. Suman's study from KM Mumbai, published in 2008, carried out between I think 2000 to 2003 or 2001 to 2004, but published in 2008. 103 babies in each group, and KMC babies had better weight gain, again better head circumference, better length, which we now generally accept, and of course lesser hypothermia, hypoglycemia, and sepsis. So now coming to the benefits of KMC, I'm sure everyone knows all these benefits, and I will not go much into detail. So breastfeeding, thermal control, early discharge, decreased mortality, reduced neonatal pain, improved maternal attachment, decreased maternal depression, and neonatal transport and decreased apnea, and decreased infections and better neurodevelopment. There's not a lot of literature on better neurodevelopment or good literature, but we'll discuss that a little bit more in detail. And I will go through all the other benefits very rapidly, just showing a few things. So if you look at breastfeeding, there are a host of studies which show that KMC improves the amount of breastfeeding, amount of breast milk produced, duration of breastfeeding, duration of exclusive breastfeeding, and so on and so forth. So if you look at whatever parameter breastfeeding you kind of look at it, KMC has shown that it improves breastfeeding. No doubt about that. Thermal control. We have published a paper which shows that skin to skin care at birth improves thermal control and prevents hypothermia, but this is actually a very old paper, 1980, not very far from when the breastfeeding was started. Now, why I want to show this particular paper is because it's very interesting slides, graph. If you look at the top graph, this is baby kept on skin to skin care at birth. Okay, this is from minutes from delivery, 3 minutes, 6 minutes. So this is not technically KMC, but this is skin to skin care at birth. Baby is kept on skin to skin care at birth, and as it goes as it goes up, as it goes up, wait, as it goes up, you see the temperature is always high. But if you look at a baby here, now this this one is baby is kept uh, on the incubator, okay, and then it remains here. And these babies are kept on skin to skin care, okay, and then they're kept on incubator. So look at this, skin to skin care and transfer to warmer. So if you see babies who are kept on skin to skin care, actually always have temperatures which are pretty normal. So very interesting, and we the WHO guideline is to keep babies on skin to skin care for at least 1 hour after birth. And you can see this on this particular slide how very useful it is, and it's a recommendation, but it's not really followed in most places. So and it talks about oxygen consumption. So oxygen consumption during skin to skin care was not significantly higher than in the incubator. So another skin for temperature is for rewarming. Skin to skin care was equally good as well as incubator for rewarming. So thermal control we have looked at early discharge. This is the AIM study. Again, it shows that babies in the KMC group are discharged early, and this is kind of standard. Most people who have started using KMC between 2000 to 2015 would have experienced that babies who received KMC get discharged early, and I think as of now most places do KMC regularly. So there are very few babies without KMC. So I think most people won't note that, but people who have kind of transition from plain incubator care or conventional care to some babies getting KMC and others not getting because people are not sure. And then later on, you know that babies who got KMC got discharged early. So this has been shown in studies also. Again, here this is Dr. Suman's study where it shows that you can have better average weight gain and again discharge. Decrease mortality. I will skip this because the reason why these slides are here. These are slides from this International Journal of Epidemiology paper in 2010. So this was the first paper before the Cochrane review in 2011, which actually showed that kangaroo mother care can reduce neonatal mortality. Okay, and they also did meta-analysis of not only RCTs but also studies which were kind of not RCTs. So they analyze observational trials also. Okay, so that's this paper is anyway available for everyone to go through. And so here they had included Dr. Suman's study, Cattaneo, this is the Italian study, the 1997 Charpak study, Sloan study, this is I think from Bangladesh, Suman Dr. Odani study from 2007. So what in 2010 was concluded was the major mortality reduction for neonatal mortality in babies whose birth weight is less than 2 kg, with even greater reductions in serious morbidity. And so all babies who are less than 2 kg should get them as soon as they are stable. So we are actually around 9 minutes closing. So in about 6-7 minutes, we'll switch to the other link. Major mortality reduction for neonatal mortality, and so a lot of neonatal deaths can be reduced because of kangaroo mother care. Reduce neonatal pain. So this is well known. Our center has actually published probably more than 10 papers which show that kangaroo mother care is equivalent to other pain reducing measures or better than no kangaroo mother care, and so on and so forth. But very clearly, if you do procedures, painful procedures on a baby who is receiving kangaroo mother care, baby does not or experiences very less pain. Very easy to point out. These are older papers in 2008, etc. And this is one of our first papers that we published in 2012, which showed that even giving KMC for as period as, like, you put a baby in skin to skin care KMC position, and after 15 minutes you do a heel prick, baby will not feel any pain or will feel very less pain. So this was one of our first papers. Subsequent to that, we have published multiple papers on KMC and pain. Improved maternal attachment. I'll go through this fast, but this is a paper from Haryana, Geeta Gatwala's unit, where they looked at that there was a shorter stay in the KMC group, which we know, and they looked at attachment scores, and it was better in the KMC group. Okay. So decreased maternal depression. There's a systematic review out which shows that KMC reduces postpartum depression significantly. So this is not there on the slide, but it is a systematic review out which is published in Bulletin of WHO, which shows that kangaroo mother care reduces postpartum depression significantly, and postpartum depression is not uncommon. As a general population, 10 to 15% of mothers have postpartum depression, which usually begins not in the during delivery time or the first week after delivery, but generally by at the end of first week, or definitely by the second week postpartum. So it is slightly delayed onset, and for babies who are smaller, preterm babies, because the mother is under a lot of stress, it is likely that many of these mothers also would have postpartum depression, and it is manifest when they are in the NICU for various reasons. We'll look at some of the reasons later on. But when these mothers give kangaroo mother care, their postpartum depression rates would definitely come down. Neonatal transport, I have some old slides, but we have done KMC transport and we have found that it is useful. Decrease apnea, again well-known effect. Decrease infections, again well-known. So this is again from one of the first studies from Colombia. Better neurodevelopment. So a lot of my slides on better neurodevelopment are going to be there now, and I'll go through them fast. So this is again babies KMC infants at higher IQ than those given traditional care. This was published in 2003, and this is 431 babies who were randomly assigned to KMC or traditional care. Okay, and so this is, give me a minute again. So the comparison of KMC and traditional care again shows that babies who get KMC do much better. Okay, so I'll skip this. So these are slides from the next maybe 10-15 slides are from Dr. Ruchi Nana's presentation done recently. And so it talks about KMC and neurodevelopment. One is when you start KMC, as I talked about initially, it allows babies to become physiologically stable. Uh, Thousands of, not thousands, lakhs of neural connections are formed every second in the newborn baby after birth, and giving KMC facilitates formation of neural connection because it ensures sleep in the baby. It also ensures reduced stress. It ensures reduced pain. And so this enhancement of synaptic efficacy is there when baby gets KMC. And there is connectivity of cerebral motor pathways. And one of the things that we believe is there is improvement in cerebral hemodynamics. So we did a study on this and we have published it, and I'll show it in the further slides. And that might be the reason why there are better long-term neurodevelopmental outcomes. So we'll come to the slides on better neurodevelopmental outcomes. I showed a few slides, but they were not very good studies, but there are long-term studies in adolescents on better long-term neurodevelopmental outcomes, which I'll be sharing. So cerebral hemodynamics, we have to understand that the ability to control cerebral blood flow is varies over a certain range, and it is limited as compared to children and adults. And because of impaired cerebral autoregulation, we all know this. The impairment increases with decreasing gestational age in more premature babies, and there is a pressure passive cerebral circulation. And this is the reason why we say in preterm babies, etc., we should not be giving pushes, or we should not be giving hypertonic fluids rapidly into the baby. So that can cause IVH, etc. This is one of the reasons why we talk about cerebral autoregulation. So when we talk about autoregulation, myogenic reflex, arteries constrict when transmural pressure increases and dilate when pressure decreases. Okay, and in intact cerebrovascular autoregulation, clinically stable in preterm infants. And here, cerebral blood flow is unaffected by fluctuations of mean blood pressure within the physiologic range of 25 to 60. So you have to have a stable cerebral blood flow, and this can happen in stable preterm infant. So you can look at this. This is your mean carotid artery pressure, and this is your normal between term. And this is so. In the next slide, you can see when there is pressure, passive cerebral blood flow. Moment your blood pressure reaches here, you will have higher cerebral blood flow. Okay, you will have higher blood pressure. So this is pressure passive cerebral blood flow. You basically have immaturity of the cerebral nervous system in preterm infants, and you have higher blood flows in babies where so this is so what does KMC do? KMC improves this autoregulation. Let's look at this. It's functional in normotensive but not in hypotensive VLBW and ELBW infants. Fluctuating pattern of blood pressure, and there are similar trends in cerebral blood flow velocity. In hypotension, there is a parallel decrease in cerebral blood flow. So these all sensitive changes in heart rate, mean blood pressure, and so on and so forth. Whenever there is moderate hypocarbia, we have seen this. There's reduction in cerebral blood flow, and when there is hypercarbia, there is increase in cerebral blood flow. These are well-known effects. KMC is known to stabilize cardiorespiratory parameters. There is lesser variation in heart rate, respiratory and oxygen is generally stable, and lesser fluctuations of BP and improved perfusion reflex.
Excuse me, sir.
Yeah, I think I'll shift to the next one. Yeah.
Only 1 minute is left, so I request everyone to join with the second link, which has been already sent in our Telegram group. Thank
I'll
you.
just send it. Yeah.
Yeah.
Okay, so we talked about KMC, effect of KMC on physiologic stability. There's an improvement in oxygenation when you give KMC. Upright position of KMC will increase the efficiency of diaphragm and pulmonary function. People have looked at needs before, during, and after KMC. We don't have needs; is very expensive. We are trying to get one for a unit, but I don't know if any other units have it. But something this one they looked at needs for brain circulation. They found that there's stable mean cerebral regional oxygen saturation throughout KMC duration. But since we could not do NIRS, we did something else that looked at physiologic stability. Let's skip all these slides. So this is a commentary published by Dr. Ruchi Nanavati and Prashant on cerebral hemodynamics in preterm infants. And this is a commentary on our paper. that we published last year, I think in January, which looked at conglomerate care on cerebral hemodynamics in preterm neonates by using transcranial Doppler sonography. And our babies are similar to what everyone has, 32 to 33 weeks, not very small, 1.6, 1.9. And even here, KMC improved cerebral hemodynamics in clinically stable preterm infants. You can look at various CBF parameters. There's a correlation between birth weight and cerebral blood flow. All these parameters show that the cerebral hemodynamics was kind of quite stable. This is a paper published in Italian Journal of Pediatrics. Again showed parameters in supine position before KMC and 30 minutes after KMC. You can find that the parameters are showing an improvement. And this is a study published from Dr. Arti Maria's unit from RML Hospital, New Delhi, which looked at cerebral blood flow. So these are 3 or 4 papers. And another paper that is being, I've not shown the data, but this is that is unpublished data from KM Mumbai, which has similar data. That cerebral blood flow kind of improves after a baby is put in KMC. So we talked about, and so that's the end of the slide which I got from Dr. Ruchi Nanavati. And now again, we're coming to, so we looked at neurodevelopment. We talked about why KMC kind of stabilizes the baby and how stabilization the baby has got an effect on the cerebral circulation, and why the cerebral circulation is important for the baby per se. So all this also has an impact on cognition, and KMC is postulated to improve brain function. I showed you a slide. We looked at IQ of babies who had KMC and who did not have KMC, but that was an earlier paper, and that interpretation was done before the children had turned adolescent. There are various reasons why cognition can improve. Sweet touch, smell, stress, and pain kind of effect are affected when baby is in KMC position. Of course, we know that breast milk production and effects are improved, and there is improved parental mood, activity, and depression again, which kind of affect care of the baby. All of these have an effect on neural connections, and poor sensations, either pain, increased stress, or not poor sleep, leads to poor neural connections and synaptic connections and decreased sensitivity, and that of course will lead to poor brain development. And I'll skip this because we looked at it. KMC improves parental mood, activity, and depression, causing them to be more involved in care and improved caregiving practices. So, one of the most important reasons why KMC improves neurophysiological outcomes is sleep organization and brain maturation and its effect on brain complexity. Okay, so there are various phases of sleep. I will not go into details. It is important for long-term memories and learning. Uh, So sensory system development, creation of long-term memory and learning, and preservation of brain plasticity are all affected by sleep and sleep cycles. I don't know if you know, but babies do not sleep longer than a minute in the NICU. They may look asleep, but they are not sleeping. Their sleep cycles are never completed. So babies basically in the NICU are always awake, though they might look to be sleeping. So when I ask these questions, like I asked a question yesterday, people said babies sleep for 6 hours, 24 hours, 20 hours, or when I said they sleep less than people sleeping in the lecture, then people said maybe 2 hours. But in theory, they don't sleep less than 10 to 20 seconds. Okay. And this sleep deprivation, so anyone who is sleep deprived knows how it affects the mental capacity. So these babies are actually sleep deprived in the NICU. Okay. So it's not a passive process, and there are various cells with stimulate activity, and there are EEG waves which can look at how this is done. So REM sleep deprivation between 30 weeks of gestational age and 4 to 5 months results in a delayed or disordered development of all of the systems that are there above. Okay. There's a very chaotic version of cycling pattern, and incubator infants have only 10 to 20 seconds of quiet sleep, as I said earlier. Again, for various reasons. And KMC increases quantity of quiet sleep improves non-chaotic sleep pattern and causes normal sleep cycling, and causes less sleep arousal and heart rate and respiratory rate according to the sleep cycles. Now, preterm sleep cycles require generally 60 minutes to complete, and within 5 minutes of onset of KMC, cycling begins. This is the main reason why KMC is given for 1 hour and not shorter than that. Okay, so this is the main reason why this happens. Cycling is needed for normal growth, and we looked at this earlier. So there are various studies which have looked at this in detail. That babies who received KMC from 30 to 20, 30 to 40 weeks had better brain maturation. Okay, and uh, this one showed that it was even better than compared to full-term infants. Okay, there are EEG studies which look at that, and again looked at studies and sleep cycle. So preterm infants who experience KMC at fewer REMs, longer sleep cycles, higher percentage of quiet sleep, and lower respiratory ratio compared to both non-kangaroo mother care groups, indicating greater respiratory regularity. So I'll skip this because we kind of established that sleep is improved by giving KMC, and people would have seen. So a 10-year assessment, and this is important because a 10-year assessment, they found that kangaroo care has a lasting effect of at least 10 years on the function of the autonomic nervous system. This was in 2014. Mental development we have looked at. So the same paper in 2014, Feldman, showed that babies who received kangaroo mother care experience higher executive functioning at 5 and 10 years assessment when compared to preterm non-KC group. Again, showing that improved cognition, improved mental development is there in their babies who got kangaroo mother care. So I will skip this. I've discussed this. I've discussed this. I've discussed this. Now this is the paper that I was coming to, and the subsequent paper published in 2012. This looked at, if you look at the authors, there's Natalie Charpak, and there are people from Canada. So what happened here is they looked at those babies in the 1998 paper, the proper randomized control trial. The trial got some completed, I think 1995 or so. So by the time it was 2012, the babies, the children were almost 15, 16 years of age. So what they did in this 16-year-old adolescents, they applied transcranial magnetic stimulation. They picked up 39 adolescents who were premature babies, 21 who received KMC and 18 with no KMC, and 9 adolescents who were born at term, to see the functional integrity of motor circuits in each atmosphere and between atmosphere. So motor planning and colossal function. So they would put a magnetic stimulation here on the brain, and then they would look at the time that the neuronal impulse has to pass to the tip, okay, of the motor thing. So we'll skip this, and basically it looks at all this. Okay, the TMS outcomes are similar between KMC and term adolescents, with typical values in healthy adults and better than in controls. KMC adolescents presented faster conduction times, showing more efficient M1 cell synchronization and interhemispheric transfer time, with a better, more frequent inhibitory process with a better control between hemispheres. And enhanced synchronization, conduction times, and connectivity suggests that KMC positively influence the premature brain networks and synaptic efficacy of up to adolescence. These are figures from that which kind of say what I said. That was in 2016. This paper came out. Basically, 2017, 20-year follow-up of kangaroo mother care follow-up versus traditional care. The same authors, you can see Canadian authors and people from Colombia. What they found, out of the 746 of total 494 out of the 716 participants, the original city were traced, and 441 were re-enrolled, resulting for 264 participants were. They found, as I said initially, the 1 year IQ, which was done 1 year, KMC at 1 year, which was there, and that study kind of, those babies had similar outcomes at 20 years. Okay, so what it means is when you evaluate babies on follow-up, what outcomes you'll get on 1 year follow-up will be consistent with what will happen to them in adolescent life. So KMC parents are more protected and nurturing because there was reduced school absenteeism, reduced hyperactivity, aggressiveness, externalization, and socio-deviant conduct of young adults. Very important because this is Colombia, where drugs and narcotics and crime is very high. And very significantly, neuroimaging showed larger volume of left quadrant nucleus in the KMC group. So basically, it showed that brain, not only brain function improved, which we saw in the 2012 study, but also the brain matter also had, there was more brain matter in this particular area. So that's significantly larger cerebral volumes of total gray matter, cerebral cortex, and left quadrant nucleus and controls. Uh, Very interesting is the volume of the left quadrant nucleus was very clearly related to duration of in the kangaroo position. That means the more the amount of KMC that you give, the larger the volume. Hence, the push for doing more kangaroo mother care for in most guidelines. Doing kangaroo mother care for 1 hour, 2 hours, or 3 hours in a day is not sufficient. The more KMC that you do, the more it will benefit the baby. The more it will get to sleep, the more motor reorganization or neuronal reorganization that will happen in the brain. So I'll skip the slides. And I think because I've said 9:51, we have discussed all this. This is our study. This is published, I think, 2015. Okay. We looked at how our KMC hours went down because people who were very for KMC kind of left the NICU. And the residents change, faculty change a little bit. So we need more KMC champions to establish a culture. This is, I will not do these slides, but these are basically published in Indian Pediatrics in 2019, implementation of kangaroo mother care. Look at the bottom. It's for implementation of kangaroo mother care. Myself and Nitesh have published this paper. And we look at problems faced during implementation of kangaroo mother care and how it can be improved. So I'll skip all the slides because they're quite in detail and will take 15-20 minutes. I'll go to the IKMC slide, which I promised. You might have seen these slides in another conference or whatever, but I thought it is worth repeating. This is the immediate kangaroo mother care for the baby. This was published, I think, in 2021, if I'm not wrong. This is the study which was done across various countries, Nigeria, India, Tanzania, Malawi, etc. And this talks about, we know all this, we don't need to go into this detail. So at that point of time, and what was the current WHO recommendations at that point of time, not now, for babies less than 2 kg, after the baby is stabilized, and as much KMC as possible. Okay. And what did the review show? I showed you the review in 2016. The review said 40% reduction in neonatal mortality and sepsis reduction, hypothermia reduction. So we looked at the major improved thing which was there. So what are the issues? Why was the intermediate KMC trial started? Most of them were started after the when the maximum babies have died after the babies are stabilized. So most of the time they included babies where average days was 3 days. So we know that early neonatal mortality happens in the first 3 days, the first 7 days. So most of the babies were put in KMC position after this period had kind of passed. Most of the preterm babies die within the first 24 hours. Okay, and so most of the preterm deaths occur before KMC can be initiated as per guidance at that particular point of time. So the point was, if you start KMC right after birth, does it improve newborn survival? And there was a reason why this was done. And there was a study published in Acta Pediatrica. This was, I think, in 2010 or 2011. I can't remember the year, but this was this was published. This is a study out of Vietnam. Kim Chil-nung recently presented at a KMC conference in Ahmedabad in December. So they looked at, they found that newborn low birth weight babies stabilize better in skin-to-skin contact rather than when separated from the mothers, a randomized control trial. So Niels Bergman was a driving factor for this particular study. He had earlier published this study in South Africa. So you can see this is South Africa. So he along with his wife, they do a lot of KMC studies, and they had shown that there was improvement in what do you say, Uh, they if you start give immediate KMC or skin to skin care after birth, even in small babies, 1,200 to 2,200 gram babies, they stabilize better. So he did this study first in South Africa. In that RCT he found that it was useful. He followed that study with a study in Vietnam, and they found it was useful. So based on these two particular studies, WHO funded us immediate KMC study across all those countries that we saw in our earlier slides. Okay. Multi-country study, babies between 1 to 1.8 kg. KMC started immediately after birth. And in the controls, babies got KMC, but after the baby was stable. So here KMC was started right after birth, and here after KMC was uh, baby was stabilized. So both arms of this particular IKMC trial got KMC. Only thing in the intervention group of the IKMC trial, KMC was started at birth in those babies between 1 to 1.8 kg. Okay, so as soon as after birth, throughout MNICU and continuous KMC. And so baby receives care in warmer or incubator. And after baby starts recovering, brief sessions of KMC. So 1 to 1.8 kg. Okay, various exclusion criteria, which we will not go into detail. Again, most of the thing people got counseling and medical care for mother, etc. So these are called as MNICUs, where mothers and babies were kept together right from delivery. Okay, so many of them were modified. Okay, they got CPAP, etc., ventilation, right at in the ICU itself. So I think they had eliminated. If you look at the exclusion criteria, uh, neonates unable to breathe spontaneously within 1 hour. So babies who are on full ventilation, invasive ventilation wouldn't be there in this particular study, but CPAP would be there. You can see babies with CPAP or room air over here, and they found that babies who got in the KMC study, there was around 17 hours per day of KMC which was there, and in the control group, babies got KMC after the baby was stable. This is their flow diagram. They had this immediate KMC, they were around 1,609 infants, so including twins, and 1,600 to conventional KMC. So if you can see here, there is no difference between both the groups. This is a NAGM study, and you can see that there is a difference in death. Okay, death between enrollment and 28 days, primary outcome, and death between enrollment and 72 hours after birth. So 28 days. So within first 3 days, there was not much difference, but at 1 month of life, there was a difference between the groups. Okay, again, hypothermia and suspected sepsis was different. Secondary outcomes, other secondary outcomes, there was not much change. And other indicators which generally we looked at. Sepsis, again, you can see is less. Okay. So what they found was, if you give immediate KMC for babies between 1 to 1.8 kg, it reduces the risk of neonatal death by 25%, which is an additional 25% over the 40% reduction that we saw when babies got KMC. So this is an additional 25% over that 40%, which is already there because of stable babies getting stable KMC. So immediate KMC provided to every 27 babies saves a life, which means around 1,50,000 lives globally every year. And so this is something which is very significant. So I think with that, we are at 10 o'clock and I have stopped presenting. Been fast probably, but that's fine.
Yeah. Sir, you are very on time. At sharp 10, you stopped. So
Yes,
thank you for being on time. Dr. Abdul also requested us to limit session for 1 hour only. So I think you have done a great justice for this topic, though it requires a lot of effort to present these many studies in short time. But I congratulate you, sir, for this hard work you have done. The session is open for the questions if anyone has.
So we did not do the implementation slides. Those slides I had skipped, but it is there published in Indian Pediatrics, and anyone can look at those particular studies.
Sir, meanwhile, any other student asked question? I asked question to you. How can we achieve KMC duration in NICU, which is a tertiary care NICU, for more than at least 8 hours a day? Because many times mothers are sick and there is no separate space for father. So privacy is a problem. So do you have any idea how to get through and have a KMC more than 8 to 12 hours in a day?
So there's this concept of alternative KMC providers, AKP. So you have to look at other family members, may not, if not the father, maybe the mother, mother-in-law, sister. So anyone else can definitely give. But giving more and more KMC is definitely very useful. So, and another thing is that I think everyone who practices neonatology should be giving KMC themselves. So I think I would suggest all the residents and who are attending should probably give KMC during when they're doing the postings in an ICU. Not like every day, but maybe once a month or once in a week, or 2 hours for a particular baby would help you understand this much more immensely. Your respiratory rate and heart rate also will stabilize.
Got it, sir. I think we are not having any question. Dr. Desmukh has congratulated your presentation, sir.
Thank you, sir, for attending. Thank you very much. Sir has left. I think I don't know. Is there? Can't see him.
Probably sir has left.
Yeah.
Yeah, I think, sir, we can now close our session.
Thank you very much. And I hope
Thank
it.
you very much.
Yeah. Bye.
Bye, sir. Yes, thank you, sir.